What happens when the doctor who spent a lifetime saving lungs suddenly needs a new pair himself? A lung transplant was uncharted territory for a lung cancer patient like our guest. Today, we're joined by Dr. Gary Gibbon, a pulmonologist, to talk about the multi-organ transplant that saved his life and gave him a second chance. I'm Dr. J. Rutland, and this is the Health Exchange. Let's get into it and talk about how Dr. Gibbon went from doctor to patient to doctor. Dr. Gibbon, do you mind if I call you Gary?
Absolutely.
Please
call me Gary.
And please call me Jamie. You have a unique story, and I know that's happened after you had practiced for a number of years. But before we get into that story, I want to know what drew you into pulmonology.
Well, Jamie, I moved from Cape Town, South Africa, where I went to medical school, to Boston to do my internal medicine residency at the Brigham. And the Harvard affiliated hospitals that I residencied in had a tremendously strong pulmonology program. So I was drawn to not only the critical care part of pulmonary, but also the interventional part of pulmonary. So that's really, I think, what shaped my love of and my choice to go into pulmonary and critical care.
Now, you've been practicing in Los Angeles, or you practiced in the Los Angeles area for a number of years?
Yes. So after I finished my residency in Boston, I came out here in midwinter there. We just had a snowstorm, and I came to interview at Cedars-Sinai for a fellowship. And it was one of those beautiful days in the winter, in midwinter in Los Angeles. And I remember after the interview, I took a walk down on Santa Monica Pier, and it was gorgeous. And I'm like, okay, I'm taking this job. If they offer it to me, I'm going to move here. And that's how I got to Los Angeles.
And this is like what, 1980?
Mid-'80s, yeah.
Yeah, mid-'80s? Wow.
Yeah. In fact, I arrived here during the second Olympic Games in 1984.
Oh, wow.
So I arrived here at the beginning of the Olympics.
Wow. I want to transition to a portion of your life where you went through what you probably watched hundreds or thousands of patients go through. And I want to talk about March of 2023. What happened in March of 2023?
Well, interestingly, it started the end of December 2022, actually. I went on a long trip back to Cape Town, South Africa to attend a relative's wedding, my niece's wedding. And when I got there, my family who hadn't seen me in years said, "Oh my gosh, are you okay? Are you feeling all right? You've lost so much weight. You look gaunt." And I'm like, okay.
Yeah.
Sort of check that box, think about that and get vigilant. And in fact, I'd lost about 20 pounds.
Wow.
And so when I came back, I went right back into my office work again, but I sort of had in the back of my mind that I should get checked out. Then I developed a cough during the month of February of 2023. And I thought, I just had some bronchitis. I took some antibiotics and I felt a little bit better, but the cough didn't go away. And so I went to get a chest x-ray in early March, and it showed this gigantic mass in my right upper lobe.
And you looked at your chest x-ray, I'm sure, before.
Well, I remember the tech saying to me, "Oh my gosh, you've got pneumonia." I'm like, "Well, let me take a look at my x-ray. Do you mind?" And she's like, "No." And I said, "I wish that was pneumonia."
So you sort of knew.
I knew.
Right or left?
Right upper lobe.
Right upper lobe.
Well, as it turns out, I then had a CT of the chest. It was not just confined to my right upper lobe, but in fact, it was affecting my middle lobe and the superior segment of my lower lobe. So all three lobes were actually involved with this mass.
You guys, when you're looking at the lung anatomically, there's a right lung, there's a left lung. You can see a picture of the lung behind me. You have your airway, your trachea, which travels down, breaks into the right and left mainstem bronchi, and then you have lobes that basically evolve from there. So you've got an upper lobe on the right, you've got a middle lobe on the right, and then you've got a lower lobe on the right, and then there's further subsegments. When you're looking at chest x-rays have 4 different densities that you can see really well. There's metal density, which is your bone, so you can see a bone really well. There's air density, which is black. You have adipose density, which is like a little bit grayish. And then you have soft tissue density, which is more white. Now, the way that I always like to describe it, because I think people understand it better, is the chest x-ray. When you have more white than you should, it's like the only time in the world where being white is a bad thing. And so what he's saying is when he looked at his chest x-ray, he saw too much white in that right lung, especially near the upper lung field on an x-ray, right? And so you have all this white. And so you can see it almost right away. And the interesting thing about what Dr. Gibbon is telling you right now is he gets the x-ray. The tech says, oh my gosh, you've got pneumonia. Dr. Gibbon says, I don't have pneumonia. I don't have symptoms of pneumonia. I don't have a fever. I don't have any of that. He looks at that and he says, I wish it was pneumonia. Why did you say you wish it was pneumonia? What was going through your mind?
Because I knew it was a malignant cancer.
And again, as a physician, somebody who'd been doing it up to that point for 50 years, sort of what's next, what's coming, what needs to be done. And you're thinking about all of these things, right?
Right.
And with cancer, the biggest thing is stage. And the way that we stage cancer is it's based on, first of all, where is it? If you have a cancer in an organ, it's going to be a stage 1 in that organ. Then the stage is based on how big that mass is or how far those cancer cells have traveled. Are they in the lymph tissue, which is kind of the freeway system for white blood cells that cancer cells break into and travel far? Are they in lymph nodes, which are kind of like the neighborhoods of these white blood cells? Again, cancer cells break into these neighborhoods. So if they're in these local neighborhoods and cancer cells are there, the stage is higher, right? Stage 4 is sort of distant, all over the place cancer. Stage 3 is like it's gone a few neighborhoods over, may have traveled a little bit distantly, but it's definitely in a few neighborhoods away. Stage 2 is like you have this big mass. It might be in a lymph node next to where the mass is. And then stage 1 is the mass is just there. When you went through your testing, what did you have done and what stage were you?
First of all, I had a chest CT after that chest x-ray. And then I had an endobronchial ultrasound biopsy.
Mm-hmm.
And then I had staging at that same time, as you have explained, of the lymph nodes. And one of my neighboring, as you've described it, lymph nodes had cancer cells. So I was a stage 3.
An endobronchial ultrasound, you guys, is when we take a bronchoscope. So anybody that's had a colonoscopy knows what a colonoscopy is. It's a video camera through the anus into the colon. You can see the colon very, very well. A bronchoscopy is a similar thing, just in the lungs, right? You actually ultrasound the lymph node, and you take a needle through the scope, and you biopsy the lymph node. You look in a microscope, and you see if there's cancer cells present, which is what he's telling you. And he had that done. Now, as soon as you were stage 3, what did the doctors do next?
As you know, the best way to cure lung cancer at any stage is surgical removal. I had a type of non-small cell lung cancer that would be amenable to surgical resection if it was not that large. It was 9 centimeters in diameter, and if it hadn't affected one of the neighboring
Lymph nodes.
mediastinal lymph nodes. I was not at that particular stage a surgical candidate.
Right.
My oncologist told me that the best way to start with this would be to do something called, and you're well aware of this, called neoadjuvant chemo and immunotherapy. That meant systemic treatment with 3 intravenous drugs, 2 chemotherapeutic drugs and 1 immunotherapeutic drug.
Neoadjuvant means like before you have a definitive therapy, a definitive surgery. So they're going to give you these molecules to try to shrink the size of the mass, reduce the amount of cancer cells that are in the system, and then you would go through a surgery.
Yes.
Now, I want to know, when you get that diagnosis, you know what's coming, you know what's next. I want to know, you've completely flipped. You've gone from somebody that's on the outside looking at people, taking care of them, to somebody that's now in the system, going through all these things. Emotionally, with your wife and your family, I'm sure you went through some things, but from a patient perspective, is there anything then that you that you take back? You're like, God, I'm glad I experienced this because I want to do this better.
Well, Jamie, the first thing I felt was shocked. I mean, there was an extreme irony as well that a pulmonologist would show up with a stage 3 lung cancer. And after I got over that shock, something amazing happened. I suddenly developed this incredible will to live. My mindset flipped to a survivor type mindset. And I brought up all these survival skills, like not just will to live, but resilience, calmness under pressure, hope, and not despair. I didn't say, oh my gosh, I got advanced lung cancer. I'm done. I didn't approach it like that at all. I went straight to my oncologist, and he immediately started treating me with chemotherapy and immunotherapy with the hope that this large tumor would shrink down small enough that it would be surgically resectable without me having to have a pneumonectomy.
That is an amazing mindset to have. You have this amazing, I don't even know if it's a shift because you probably always had that mindset, but you have this mindset of, I'm not going anywhere. We're gonna get through this. Like I'm going through this. You got 3 molecules. You got paclitaxel, carboplatin, and nivolumab. Now, just real quick for you guys, whenever we think about cancer, what we're thinking about is we're thinking about cells that are abnormal, that are undergoing mitosis a lot. So they're dividing a lot and they're multiplying. And the way people actually die from cancer is because the cancer cells need blood vessels like everybody else. And so they just take all of the energy and the nutrition away from all the healthy organs, and the cancer cells just grow, 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 grow. What we did medically is we took advantage of that. And so every cell that grows fast, that's what they target. So paclitaxel targets microtubules, which are important in cell division. You basically inhibit the microtubules. And so cells that are dividing fast die. And the cells that divide fast are your white blood cells, your gastrointestinal lining, GI tract cells, because they pretty much change themselves out every 24 hours. So that's why people have nausea, vomiting. That's why people have low neutrophil counts, because those are the cells that divide fast too, but it also kills cancer cells. Carboplatin, which targets DNA. And so when you target DNA, basically when cells divide, they have to split the DNA. So they can't split the DNA. So the cells that are dividing die off. Then you have this molecule called nivolumab, which we call immunotherapy. As medicine has gotten better at what we do, basically we can look at cells and we understand the receptors that are on cells. It's kind of like going to somebody's house and seeing what type of windows they have. Now, based on those type of windows, we begin to understand how those windows are beneficial to that cell or detrimental to that cell. In some cancers, what we've noticed is that cancer cells are smart. So what they do, because you would always ask yourself, why doesn't the immune system recognize cancer cells? Well, cancer cells basically say, I'm going to shut off this receptor so the immune system doesn't get active. So it doesn't activate. So it doesn't see me and I can just continue to divide and live my life and be left alone. So that's what cancer cells do. What nivolumab actually does is it turns that back on. And so you get the immune system to recognize the cancer cells. Now, what happens actually is when the immune system gets turned on, it can almost over recognize things, right? And so not only is it going to fight your cancer, but it may fight you. And so what happened when you went through those therapies, Gary?
Well, initially, Jamie, I tolerated it very well, and I was excited. The first follow-up CT of my chest showed that the primary cancer had shrunk.
Mhm.
So I was in a great space at that time, and I was still working every day. I was going into my clinic, in my office, seeing patients every day, doing my usual work.
Did they know what you were going through, your patients?
Some not, yeah. I would try and, schedule my infusions
Yeah.
at a time when I wasn't seeing, patients or didn't have a schedule at that time. But they knew, I was spending time away from the office a little bit more. And then something weird happened. One day, I had gotten an infusion in the morning, and I had started on a course of radiation. And I came back to my office with my wife, and I was ready to see patients.
Hold on,
And
Gary.
Yeah.
I want, because this is inspirational and this is motivating and this is all the things that you probably weren't thinking it was, but it really was. You got chemo in the morning, radiation at lunchtime, and then you're like, okay, I'm going to go see patients. The work ethic and the determination to do something like that is absolutely amazing, inspiring, and I want to make sure that you know that, because that's amazing.
Thank you.
So you're going to go to clinic.
Yeah, I wasn't thinking anything of it because I tolerated it quite well up until that point. And then it just hit me. I was in the office about to check a patient in, and I got chills and sweats. I took my temperature. I had a temp of 104. And I took my blood pressure, and it was 74 systolic blood pressure. So we had low blood pressure. I was febrile, and I was in shock. I was in what's called, as you know, neutropenic
Fever.
and shock.
What that means is, as a result of his white blood cells being really low, his immune system just can't recognize bacteria, can't recognize any infection that may be taking over his body. And so he's more susceptible to it. He knows that. He's protecting himself probably as much as he possibly could. But despite all of that, you got an infection. Infections can end up lowering your blood pressure because of the molecules that are housed on their membranes, especially if it was a gram negative. I'm assuming it was, but I don't know. And then when that happens, your blood pressure gets low, you get really ill, you get the chills, you went to the hospital.
Went straight to the ER. My wife drove me to the ER on the way. I called my doctor and said, I'm on the way to the ER because I'm in septic shock. And it turns out that on the chest x-ray that I got in the ER, I had pneumonia, bilateral pneumonia.
Okay.
And that was the source of the septic shock.
And then
I went through 2.5 months in the ICU following admission
UCLA?
at UCLA.
Okay.
During that time, I had progressive respiratory failure. And it wasn't only from the cancer, but I had developed new changes in my lung. I had what's called ground glass opacities, an interstitial alveolar infiltrate diffusely in both lungs. I was on high flow nasal oxygen plus a non-rebreather mask at 100%.
So 30 liters.
Yeah.
Yeah.
Also, I started developing organ failures in other organs. For example, in my liver enzymes were elevated.
Yeah.
And I developed renal failure.
Now, most people go through what you go through, and they don't understand the clinical consequences or what this means and all of that. I'm not saying they should, but as you're going through all this and as you're telling me your story, I mean, was this happening and you were completely out of it? Or was this happening and you're like, oh my gosh, my organs are failing, I might die? Did you ever think you might die?
Well, first of all, my cognitive state was perfect.
Oh my gosh.
So I thought those things.
Yeah.
I'm like, my gosh, I'm in multi-organ failure. I didn't think I was going to die. It was bizarre. I had this calmness. It's almost like calmness was my superpower.
Mm-hmm.
I had no anxiety. I had no fear. I had no despair. I'd replaced it with a set of survival skills, a set of wills to live.
Yeah.
And so even though I knew I was in dire straits, I didn't think I was going to die.
So as an ICU doctor, you guys, the easiest thing for us to do is, generally speaking, what we say is when one organ is down, we say that's 20% mortality. So if your lungs don't work, 20% mortality. If your liver doesn't work, that's now 40% mortality. If your kidneys don't work, that's now 60% mortality. Like, these patients just don't do well. And all those things kind of happen to you during this admission. And you're thinking that, and you know what it means, but you're like, I'm not going anywhere.
And you can add my bone marrow to that.
Oh,
bone marrow failure.
Oh, yeah, that's right. You had bone marrow failure because your neutrophils weren't working. Yeah, so you're just like, I know all this is taking place, but I ain't going nowhere.
Yeah.
Now, your wife is at your bedside. As somebody who was 100% cognitively there, as you said you were, what did you see on her face? Was she as calm as you?
No, she was anxious. She was worried.
Were you trying to calm her down?
I was, but she was worried. Appropriately.
Yeah.
I was in this sort of Twilight Zone. I mean, I can't explain it. You know when doctors come into a patient's room and they kind of gingerly move around and answer the questions in a very sort of circumvented type manner?
Yeah.
That's how they were approaching me and talking to me. My visitors all looked, I could see the look on their face was, well, we may not see you again kind of look, you know? And so I felt anxiety in other people of my condition, but I never thought I was going to pass. Except one time, and I'll tell you about this one time.
This was after all this stuff? Or
No,
this
that's in the ICU. I'll tell you in the ICU what happened. One night, I'm on this very high flow oxygen, and one night I just couldn't breathe. I was so short of breath. And normally I could calm myself down. Even if I desaturated when I was eating or talking, I could always just rest, take deep breaths and calm myself down, and my saturation would come back up. But this night I just couldn't do it, and I was in distress. And the one thing I was trying to avoid was intubation and mechanical ventilation. I was trying to avoid that because I knew that had its own set of complications that I wasn't, looking forward to.
Yeah.
A nurse came in for the night shift, a gentleman, his name was Richard, I'll never forget, and he sat down with me and he said, I'm going to put my hand on your chest. You just follow my hand with your breath. As my hand moves up, you move your chest out. Just follow my hand with each breath. And he sat there with me with his hand on my chest, regulating my breathing until I fell asleep. And before I fell asleep, that's the only time I thought I was going to die.
I thought you were going to tell me that wasn't a real person.
No.
Yeah.
That was the only time that I thought, this is it, I'm going to die. But before I died, I fell asleep.
Yeah. Yeah.
It was like a spiritual
Yeah.
epiphany in a way that he was able to calm my breathing. The next morning, I woke up and I was sitting in a chair upright. I had my legs up on the bed. I wasn't in the bed, I was in a chair. So I was sitting, but my legs were on the bed. So I was not in the ICU bed.
Oh my gosh.
I was in the ICU, there's reclining chairs.
You fell asleep in the bed, but you woke up in the reclining chair with your legs up.
Yeah.
Okay. So you've gone through septic shock. You're 2.5 months into respiratory failure, which means that the lungs are just full of inflammation and your balloons are just full of inflammatory cells. So oxygen is having trouble getting through. So you try to increase the amount of oxygen that gets through the tissue that doesn't have as many white blood cells. And so he's on like the maximum amount of oxygen you can provide somebody, right? 100% with a bunch of liters being pushed into his nasal cannula or his mouth. So then what happened? What did they diagnose you with?
They came to me and said, you've got pulmonary fibrosis. You've got a pneumonitis, but you also have areas of fibrosis. It's in both lungs and diffuse, and they treated me with high-dose steroids to try and reverse it.
They didn't biopsy you though, right? They didn't
No,
do a lung biopsy.
they didn't.
Those
They
on
didn't.
HRCT they saw. Okay.
Just on HRCT. And they gave me high-dose steroids, but they did that for a month. And they presented me at the Interstitial Lung Disease Center Grand Rounds, and they all came to the conclusion that there was nothing else available to me. I couldn't have any more chemo or immunotherapy. There was no immunosuppressive treatment that I could undergo or anti-inflammatory treatment. And they basically told me, they came to my bedside and said, you need to go on palliative care and prepare yourself for hospice care. We have no option at this time. And I was overwhelmed by that. I mean, I welled up with tears because that was the first time that I just let it out that this was the end. But I said to them before they left my room, I said, there is no way I'm giving up right now. I'm not going to give up. I'm going to find a way out of this. And I did by remembering what my wife had told me at the beginning of my chemotherapy. She had seen a morning show on the Today Show, a segment about 2 patients who received bilateral lung transplants for stage 4 lung cancer at Northwestern Memorial Hospital and was still alive at 1 year, cancer-free. And I remembered her telling me that and showing me the clip.
And you felt like that was your way out?
And that was my way out. So that was the light at the end of the tunnel for me. I figured if I focus on that, that was what was going to save my life. And so I did. I had my doctor's contact the thoracic surgical team at Northwestern. I spoke myself directly to Dr. Barat and then also to Dr. Nadig. Dr. Nadig is the Comprehensive Transplant Center director, and he did my liver transplant, and Dr. Barat did my lung transplants. But I talked to them ahead of time, and they said to me, only one problem, you've got lung and liver failure. And the only way to do a lung transplant for you is to do a liver transplant at the same time, and we've never done it. You'd be the first. Do you trust us? Because we think we can do it. It's a risk. It's never been done before. But if you have confidence and trust in us, we're willing to give it a go.
It's a very powerful statement when a physician speaks to you in that way.
Yeah.
If you have confidence in us, we can get it done.
Yeah.
I mean, that is a very powerful statement. But my question to you is, Dr. Gibbon, you're an allergy immunologist, pulmonologist, critical care doc, internal medicine doc. You have these 4 boards. Well, you know that you've got nivolumab-induced toxicities, right? So we know the immune system was overactive, which led to more inflammation and fibrosis. Under the influence of white blood cells and inflammatory cells, your lung will start to undergo what we call this mesenchymal transition. So basically, you're going to go from inflammatory infiltrate to recruiting over fibroblasts, myofibroblasts, which lay down collagen, lead to scarring. That's what's happening in his lung. His liver, as a result of probably activation of T cells as well, has an inflammatory infiltrate too. It's called nodular regenerative
hyperplasia,
right? So his liver is injured as well, okay? Knowing everything you know about immunology, you just had lung cancer, stage 3. Scientifically, when that doctor says that to you, are you thinking about all this, or are you like, nope, absolutely, I'm gonna get through this?
No, I'm thinking about it.
Okay.
Definitely thinking about it. Because I still had active cancer, by the way. Yes, it had shrunk down. And when I had a mediastinoscopy, that node was clean. So I had no nodal disease going into the transplant. So I knew that I was a real stage 3 and I had no nodal disease.
But they transferred you. They had to airlift you from
UCLA
to Northwestern.
Right. So once I made contact with them, they said, well, if you trust us and you have the confidence, you have to go through a bunch of tests. So they gave me a barrage of tests to go through in order to enroll in a trial that they were doing called the DREAM trial, which was the double lung replacement and multidisciplinary care study. And so I went through every test you could believe
at
UCLA, on every organ.
While you were in the ICU?
While I was in the ICU. I had a
right heart cath.
Right and left heart cath. I had an MRI of the brain, no mets. I had a full body CT and PET scan. I had a liver biopsy. I had a mediastinoscopy. I had another bronchoscopy and biopsy. And the best day of my cancer life was when they came to me and said, we're getting the plane ready for you. We're airlifting you to Chicago because you passed all the tests and they've accepted you as a patient on the trial.
Now, at this point,
I was still in the ICU.
That's what I'm saying.
Yeah.
And you're still on the 100% oxygen?
Yeah, right. I don't know, how am I going to get there, right?
No, that's what I'm saying. I'm like, were you guys, look, all planes are pressurized to about 5,000 feet. So when you're on a plane, it's like you are breathing in oxygen that has that many molecules in the air. As you travel up, there's less molecules of oxygen around. The percentage is the same, but there's just less oxygen. But you're on oxygen anyways. So you're 100% with it the entire time, which I find to be an absolute blessing, because it's a blessing for us because I can ask you questions about your mindset when you're going through all this. But you're wheeling down to the jet. I mean, are you like, I can't believe this. Like, what's going through your mind? Is your wife on the jet with you, or did she have to fly on her own?
No, she's on the jet with me.
Okay.
And before I went on the jet, they would only release me from the ICU. The attending in the ICU would only release me to the plane if I demonstrated that I could be off high flow nasal oxygen and just breathing with a non-rebreather mask, because they didn't have enough
Yeah.
oxygen on the plane to get me from LA to Chicago, and they didn't want to stop to have to reoxygenate the plane.
My God. Yeah.
So before I left, I lay flat in bed for 4 consecutive days, for 4 consecutive hours, because that's the flight, 4 hours from LA to Chicago.
Yeah.
Breathing just on a non-rebreather, lying flat while they had measured all my vital signs. And the nurse would monitor me in the ICU. I had to demonstrate that I could do that and maintain my saturation above 95. And I was able to do that.
95.
Yeah, they wanted to be now.
Where did they pull that number from? Anyway.
I don't know. They just
Yeah. Yeah.
because they thought, well, you're going to be at certain altitude, so you're at sea level, so that's compensating for the hypoxia that I would get at higher altitude. And I passed that.
You did.
And so they released me the next day, which was a Saturday. It was September 10th. I can't forget it. I remember the ambulance guys coming into my room in the ICU. Now, I must tell you, before we left, my wife and I got married. We were not married. We were
living in sin. I'm kidding. I'm just kidding. You weren't married. Okay, so you guys got married.
So we got married in the ICU before we left.
You got married in the ICU.
Yeah.
Hold on, wait. You know, all these conversations we've had before this was the one point that got left out. You got married.
Yeah, got married in the ICU.
Congratulations.
Before I left to Chicago.
Before you left to Chicago. Hey, we're getting married. I do. Let's go get a transplant.
Yeah.
2.
Basically, yes.
When patients get transferred, the physician that transfers the patient says, okay, you can go. They are responsible for you until you arrive. Hence all the testing you had. Because UCLA's pulmonary critical care doctor was going to let them go. Wanted to make sure they had done everything they possibly could. So that way the 4.5-hour flight to Chicago from LA would be uneventful. Right? So that's why he's going through all this. So you get on the jet. What do you remember the flight? Was it smooth?
I do. I remember before we left, I said to my wife and to the pilots, I said, under no circumstances do I want you to stop anywhere between LA and Chicago. I want a direct flight to Chicago. Don't drop me somewhere in the Midwest that doesn't know how to do.
You could have gone to the University of Iowa. We would have been fine.
Because they'll keep me in the ICU.
Yeah, that's true.
And intubate me and put me on a ventilator, and that'll be a production getting to Chicago. So they guaranteed me they wouldn't stop. Well, they did stop because I was doing so well. They stopped to refuel.
Oh, did they really?
Yeah, they really did in Kansas somewhere.
They stopped to wait, hold on. So they get all the way there.
Yeah.
They don't fill up their tank. They had to refuel in Kansas. Oh my God.
They didn't stop to get oxygen for me. I was doing fine.
Oh my God. To me, I know you're a patient, but you never lost your ability to be a doctor. So you're kind of both throughout this whole thing.
Absolutely. I'm monitoring myself. I'm giving the best pulmonary advice that I can, obviously, to every doctor and nurse.
Yeah.
I'm saying, look, no offense.
Yeah.
But I just have to tell you this. This is what I'm thinking, So there was shared decision making all along the way.
And you felt like that helped you.
I was the patient sharing information. Yes. Helped me 100%, Jen.
What surprised you most about being a patient?
I would say the ability to switch from a doctor to a patient seamlessly and smoothly. When I've talked about my story, I say when they wheeled me in to Northwestern Memorial Hospital, I left my doctor hat at the door. In the ICU, I was in my wheelhouse. I'd grown up in ICUs. I spent most of my life in ICUs and in critical care. So it was my stomping ground. But when I got to the transplant units, I was not a transplant physician. I was not a transplant pulmonologist.
Would you say the first time you ever let go of being a physician was when you hit that transplant?
Yeah, I surrendered immediately. I surrendered. I said, give me the protocol because you've done it before. I've seen your results. I've researched your patients. By that time, they'd done about 6 or 7. I think I was either 7th or 8th patient. So I'd seen the results and I give me the protocol. I want to follow it from A to Z and I want to do exactly what you tell me. And that was my goal. And that was my mindset.
So this is a situation where it's interesting because it's a really role reversal here. So as a physician, we have to be vulnerable at times when we're trying to relate with patients. Now you're a patient and you're being vulnerable and you're letting go of your education. Not really, but kind of. You're not actively participating in giving medical advice anymore. Was that hard? Was it easy? Was the physician there just so great at explaining? What was it?
All those things. Their team, the transplant team at Northwestern, is remarkably good. They are like top shelf professionals, from, the surgeons to the pulmonologists, the nurses, physical therapists, the nutritionists, the whole nine yards. They have a remarkable team, and they immediately make you feel at home. You're one of the family. I felt like I wasn't just a subject on a trial. They were taking me in as one of the family. I was going to be there for a year. This was their welcome. They welcomed me with open arms. They treated me like a precious person,
Wow.
a special, precious person. And they were so magnificent that they immediately put me at ease. Yes, I was vulnerable, but I immediately felt like I could surrender to them as a patient.
Do you remember any statement that was said that had a profound impact on you?
Well, there were many. I can remember one time I was struggling to walk pre-transplant, and they were getting me up, and I had tremendous ICU peripheral neuropathy and atrophy from the steroids in my muscles. I couldn't walk without two people helping me. And they would wheel me out, and I would have like 6 oxygen tanks, and I'd be on the high flow oxygen machine. And I'd walk out and could take a few steps, and then I'd have to stop because I was short of breath. And I'm like, how am I going to do this? I can't do it. And they just pushed me. They literally pushed me to do it. And when I got back from that walk, she said to me, well done. She said, all I want you to do from now until you get on the wait list is to focus completely 100% on getting the transplant. Don't think about anything else. When we make you do physical therapy, we're doing it because the transplant. Whatever we do to you, whatever test we're going to do, whatever pulmonary rehab we're going to do ahead of time, is because of the transplant. Do not lose faith. Do not despair. It's sort of like keep your eyes on the prize kind of thing. Remember why you're here.
Yeah.
You came here to have a transplant, and that's what you need to focus on. Don't do anything to disrupt that path.
Wow.
And do everything you can to facilitate that path.
Did that experience change the way you practice medicine?
Absolutely.
How so?
Well, it changed my perspective of being a patient-centered doctor.
Uh-huh.
I was in gratitude, but I also became a lot more patient embracing. They showed me how to embrace a patient because they embraced me as a patient.
Wow.
It was a fantastic learning experience. I recommend it to doctors.
Yeah.
Because we tend not to want to make that transition. We don't want to cross from the one side of the stethoscope to the other easily. We don't easily cross that way. I didn't.
So you want us all to get double lung transplants and liver transplants?
I just think we need to,
I agree.
make it simpler. And it comes seamlessly. It came smoothly and seamlessly to me. I thought it would be a huge transition. Everyone said, well, being a doctor, how did you transition to a patient? And I it just happened to me automatically, kind of.
It's interesting because at UCLA, you were a doctor. You were Dr. Gibbon.
Yeah.
You didn't become Mr. Gibbon until you got to Northwestern Transplant ICU.
Yeah. They said to me, what do you want us to call you? I said, call me Gary.
Yeah.
And they wrote up on the board, Gary.
I want to transition. We always do this quick fun segment. We're going to call it Quick Breaths.
Okay.
I'm going to ask you some questions. First thing comes to your mind. Okay. Would you rather be the doctor doing the surgery or the patient?
The doctor.
What's one thing you appreciate now that you once took for granted?
Breathing.
Best medical advice you've ever received as a doctor?
Go see the doctor.
Best medical advice you've ever received as a patient?
Never give up.
Deep breath or big laugh?
I say deep laugh, but to do a deep laugh, you got to have a deep breath.
That's a cop out. All right.
Yeah.
What's one daily ritual that feels different with your new lungs?
I'm in gratitude every day.
Did you secretly grade your doctors and nurses in your head?
Sure. Yes, absolutely.
Who was the worst? I'm kidding. You don't have to say. Just kidding. I'm just joking. Did you have experience with interns and first year nurses?
Yes.
If you had to give them one piece of advice, what would you give them?
Put yourself in the shoes of your patient.
What is it that kept you going through all of this?
I want to say my will to live, but I think it was my spiritual mindset. I prayed a lot, formed spiritual relationships with my family members, with anybody who took care of me or came into my life. They were all to me sort of like, and I don't want to get soppy about this, but they were earth angels to me. My wife, for example, she clocked 100 nights sleeping in my room with me, both at UCLA and at Northwestern. And we prayed together and we wept together at times. So it was the will to live that came from the spiritual mindset.
Going through everything that you went through, all of this, knowing how busy we are, how much we work, especially how hard you work, was going through this experience therapeutic?
Most definitely.
Now I want to get into this transplant. So you're at UCLA, September 10th, you go to Northwestern after Kansas for a minute to get some fuel. You get to Northwestern. How many days were you at Northwestern before you got transplant? Because now, did you know at that point you needed both 2 lungs and a liver?
Yes, I knew at that point. I'd had a video conference at UCLA with the surgeons, both the lung and the liver surgeon, transplant surgeons, and I knew I needed both. They were very honest with me. They said, we can't do one without the other. And so we're going to do them together. I said, okay.
Yeah, all right. Yeah.
You know, if it's going to give me a chance. I had this thing that whatever was going to give me a chance to survive, I was there for.
You know, most people probably don't think about it in this way, but for you to receive an organ, somebody has to move from this stage of life to the next, usually, unless it's a kidney. But typically speaking, if it's a liver, if it's a lung, liver is usually cut in 4 and given to 4 different people. Lung can be single, but nowadays we're doing more double. It's got to be a person. And because of your spirituality, you'd accepted that. You probably prayed for the family. But how many days between getting there and receiving?
I had more testing for 4 days. Then I got waitlisted. Then 4 days I got transplanted.
Was it smooth?
Very smooth. It was remarkably smooth. I went for 4 days of testing there, including, rebiopsying, restaging.
Yeah,
Restaging. Yeah. And then they said, fine, you're good to go. I'm like, okay, we put you on the list. The list has, a variable wait time. And it's all based on how sick you are when it comes to lung cancer. And you're absolutely right in saying that you need a deceased donor. And so you're thinking about your donor. Somebody has to die in order for you to survive.
Do you ever feel bad with thinking like that way? Because you're sitting there as a patient now.
Yeah.
You want a lung. You want a liver. You're not hoping somebody dies.
No.
But you're hoping you get a lung and a liver. What was the emotion of feeling that, like, when you're like, oh, hey, we have one? Are you like, oh, yeah. Like, what was that like?
When you get the offer, absolutely, there's this intense joy, right, and celebration. But then, as you would think, you get this feeling of, oh, somebody has died in order for their organs to be harvested and to give someone else a second chance at life. So with a death comes lives. And this beautiful donor who donated my lungs and liver also donated to 5 other recipients and saved 5 other lives.
The heart, the kidneys.
Yeah.
from a historical standpoint, Guinness Book of World Records standpoint, you are the first United States case that was ever diagnosed with a stage 3 lung cancer and was transplanted with both lungs and a liver for therapy.
Correct. That's groundbreaking. That's landmark. Because as we know, you pick up a book of pulmonology and you look at management of lung cancer, advanced stage, and nowhere in my mind do you see, oh, you can have a bilateral lung transplant if you stage 3 or 4 advanced lung cancer. It doesn't exist.
No, because everybody's scared of the immunosuppression.
Exactly. Or they don't have the methodology to prevent cancer cell spread during the procedure. The whole methodology was pioneered during COVID by this hero thoracic surgeon who did double lung transplants in end-stage COVID patients with respiratory failure due to pulmonary fibrosis. And he pioneered it and then extrapolated it to advanced end-stage cancer.
When I think about it, just like selfishly speaking, I'm like, I mean, people have bone marrow cancer. We wipe out their bone marrow and give them new bone marrow and put them on immunosuppression. Like,
Yeah.
from an organ perspective, what's the difference? Like, you know what I'm saying? I'm kind of like,
yeah. Why should that be the roadblock, right?
yeah, why does that have to be the roadblock?
Yeah.
And you're kind of that, you represent where we want medicine to go. Not saying that, we want individuals to have to pass away to have it done all the time, but I'm just saying that, like, you are a living, breathing reason and a living, breathing example of the evolution of medicine. That is what you are. And when I think about it, knowing you, the way that I've gotten to know you over the last month, you're pleasant, you are passionate, you are clearly driven, you represent medicine in great ways in 4 different fields, and you represent the evolution of medicine. To have you sitting in this chair is an absolute honor. I mean, I just want to give you that compliment. But you go through the transplant and you really have nothing bad to say about the surgery. Everything went well. What happens next? I mean, I don't know if this is all within, you have the transplant 2 weeks since you're at Northwestern, and this was 2 years ago.
That's right. I'm coming up on my 2-year anniversary, the end of this month, the 26th of this month. Next week will be my 2-year
So do you go
transplant
to
anniversary.
you go to Chicago every 6 months or something? Is that Bronx and biopsy and all?
Yeah, I have been going back, but I've also established my transplant care here in Los Angeles with UCLA in particular. But I do go back. Otherwise, I get regular care here in Los Angeles as well.
I know you have a lot of gratitude. I don't know if you've met your donor family at all.
I haven't, I haven't.
But I'm sure you have gratitude towards them.
I have great gratitude towards them. I wanted to extrapolate on that when you were asking, did I feel a sense of maybe guilt that I survived and someone had to die in order for me to survive? I did think that. But then I thought that there was a greater reason for surviving. They wrote an article in a Chicago health magazine, and the opening line to the article is, by all accounts, Gary Gibbon should be dead.
Wow.
And that is true. And so my love almost of my donor extends beyond gratitude.
I mean, it's an amazing story.
Yeah.
It's a powerful story. And I think that's one thing to take away from all this. And when I am in the ICU and patients become brain dead and they're donors, and I'm sure you do this too, the way that I talk to the family is I say, listen, his heart's going to allow somebody to live a longer life. His liver's going to allow up to 4 people to live a longer life. He's got 1 kidney for another person, another kidney for another person, pancreas for a person, right? I think that is a very, very special thing. I think it's a very, very powerful thing, and I think it is the ultimate human thing to do. It's what makes human beings connect. And literally, other organs are connected to individuals. So I feel like those individuals live through them, and you represent that. You do a lot of advocacy work now.
I do.
What's important to you from that aspect?
Spreading the word, really. Getting it known, not just to potential patients in that situation that I was in, but to their physicians. The unfortunate side of this is what I learned while I was in Chicago for a year, was that there's backlash. There are naysayers who don't believe we should be using donated organs on cancer patients. So the advocacy is in the field of transplant oncology. There's a stigma to lung cancer, as you know.
Yeah.
And I think we need to get beyond that. We can't persecute people and judge them because they have lung cancer. Every other cancer is embraced. Lung cancer is sort of like,
You did this to yourself.
yes, you caused this. And so I think we got to get beyond judging our patients.
I couldn't agree with you more. I think that's the biggest takeaway from this is sometimes, the historical perspective is absolutely wrong. If there's one thing that's consistent with society, the historical perspective is wrong.
Wrong, yeah.
Right.
Yeah.
So I think we have to embrace that in medicine. They embraced it with you, and I embrace you for being here. So I really appreciate you sitting in this chair.
Thank you, Jamie.
Where can we find you, Dr. Gibbon?
drgarygibbon.com is my website. There is my email address, which is garywgibbon@gmail.com. There's a lot of data on me on the Northwestern website as well. My story's there. So I encourage people to call me, to reach out to me if they find themselves in a situation that I was in. And I am happy to walk alongside them and mentor them in their journey.
Thanks for watching and listening and hearing Gary's story on how he went through being a doctor to a patient to a doctor. We're on Instagram at the Health Exchange Podcast. Get us everywhere you get your podcasts. We're on iHeart, Apple, Spotify, YouTube. Subscribe, do all that stuff. And we'll see you every Thursday. See you next time.